Hello, my name is Graham Finney. I'm one of the anaesthetic registrars based here at Glasgow Royal Infirmary, and I'm going to give a short talk on IV induction drugs. I'm recording this in an anaesthetic room, so if there's a little bit of background noise, I do apologise for that. So let's have a look at what we're going to cover. So we're going to have a short discussion about the common intravenous induction drugs that we use in our practice and their uses, and we're going to touch a little bit on some pharmacology as well, which I'm sure you'll be delighted to know. So there are four kind of common induction drugs that we use. This is the stuff that puts you to sleep, basically. So the most common, which I'm sure you'll have seen, is propofol, and we'll tend to focus a little bit on that as we go through our talk. Other drugs that you'll see being used are ketamine. Thiopentone is something that we used to use quite a lot, but is kind of going out of fashion a little bit. It still is used in obstetrics, and there are still certain people that prefer it for certain uses, but generally speaking, that's being used less and less. And then the fourth one is etomidate, which you probably won't see being used a huge amount, and we'll discuss the reasons why. So there are a couple of concepts that I think it's quite useful to understand before we go on to talking about the drugs themselves. First one would be, what is a bolus dose? And next we'll look at what is an infusion. Now I know that these are words that you'll have heard before, and I'm sure you understand them already, but just so that we're all talking the same language, we'll discuss a wee bit about what is a bolus, what happens when you inject a bolus drug, and how we can then think about it thereafter, and how that might cause us to modify how we inject it, how much we inject, and if we give further injections of drug. So first of all, let's think about what happens to a drug when we inject it. So if you look at the graph on the right hand side, the red X marks the point at which the drug, a dose of drug is injected. So let's say we inject 150 milligrams or 15 mils of propofol. And what we can see is a rapid rise in the blood concentration of propofol, followed by a decline in the concentration over time. So what you can imagine is that at a certain concentration the patient goes to sleep, and then once the propofol comes down to below that certain concentration, the patient will begin to wake up, and it will be a case of they will be unconscious, and then as it slowly declines, they'll gradually start to become more conscious. They'll still be quite drowsy until they've got rid of their propofol completely, in which case they'll then be back to being fully awake. And there are a few reasons why this is happening. So with propofol in particular, once you inject it, it gets redistributed to other tissues. So it gets redistributed out of the bloodstream and is sequestered in things like muscle and fat. But also drugs in general, the way that the body tends to get rid of them for the most part is that they're metabolized, most often by the liver. This can be to a more or less active metabolite. And then drugs are excreted, and most often by the kidney. Okay, so over time these processes are involved in eliminating the drug from the body. So the main things to say about a bolus as a concept is that it's a single injection of drug, and the advantage is that you get a short time to reach a desired concentration, followed by this exponential decline that you can see in the graph. Now the flip side of that is that you can easily overdose that drug and end up with other problems such as hypotension if you're not careful. with either the dose or how quickly you inject it or something like that. It's important to say, though, that repeated boluses may accumulate, particularly if the patient has liver failure or renal failure. And actually, if we'll go on to the next slide, but you can imagine it as that repeated small boluses can almost act a little bit like an infusion. So that brings us on to what is an infusion. So an infusion is a continuous injection of drugs, a continuous supply of drug into the bloodstream that causes an exponential increase in the drug concentration in order to reach a target concentration. At this point, where the drug infusion rate and the rate at which the body is getting rid of it, so the excretion rate, when those two are the same, that's what we call a steady state. Okay, and that's kind of the whole point of an infusion, is really you're aiming for a kind of smooth, steady infusion of drug, which limits the, particularly in induction drugs, the cardiovascular instabilities is probably the main thing. So what you can see from the graph on the right hand side is it's a little bit like the graph we saw before, but flipped on its side. You can see that the concentration of the drug, so if the bottom left of the graph is where we start the infusion, and the aiming for that target concentration, you can see that gradually over time the concentration of that drug will increase to the point where it then reaches the target concentration, and then what you're aiming for is for the target concentration, the infusion of drug, the rate at which that's being infused stays at that target concentration over time. So the way in which we measure infusions is a few different things. So mils an hour is commonly used for things like metaraminol. We also use it for noradrenaline and adrenaline in this hospital, certainly. You can infuse things like propofol at mils an hour, but we tend not to do that for a reason I'll explain in a wee minute. Micrograms per kilo per minute is how you see some drugs being infused. So particularly if you go to places like the Golden Jubilee, they infuse most of their drugs in a microgram per kilo per minute rate. The advantage of this is that you can imagine that 10 mils an hour of a drug for a 50 kilo 80-year-old lady is not the same as 10 mils of drug an hour for an 130 kilo 25-year-old rugby player. Okay, and CE, so that's the effect site concentration. And we see that being used for things like propofol infusions or remifentanil infusions, where that's basically the target concentration that you see on that graph. So it's important to say that these programmed infusions, propofol being a really good example of this, often start by giving a bolus, and they try to reach the target concentration as quickly as possible so that you can then keep the patient at a steady state. You can sort of gradually increase that over time if you think your patient might be a little bit more unstable, or if you're starting with some sedation and then moving more to an anaesthetic dose. But it basically, it can be programmed to give a bolus at the start, which essentially gets it up to target rate a bit quicker. Okay, so let's talk about propofol. We've obviously already touched on it quite a bit already, but it's our most commonly used induction drug, and it can be given either as a bolus or as an infusion. Its main uses are in the induction of anaesthesia, but it can also be used for maintenance of anaesthesia and as sedation, both in theatres and in ICU. So when it's given as a bolus, which is the most common way that it will be given, you often see the vial on the right, so the 1% propofol is what we most normally use. I've stated this is the kind of stated induction dose of propofol between 1.5 and 2.5 milligrams per kilo. There are huge variations on that dose depending on what other drugs you might be using to put the patient off to sleep, such as an opiate, so alfentanil, fentanyl, remifentanil. And it can also depend on the patient themselves. So whilst you might get an elderly patient weighing 70 kilos, you would give a very different dose to them as compared to a 70 kilo 21-year-old. It is used for maintenance of anaesthesia. The benefit of that is that you're less likely to feel sick after your operation compared to using volatile anaesthetic to keep you asleep. So we tend to use that for kind of higher risk cases, higher PONV risk cases. So that's given as, it's usually the 2% propofol that we use, so the 50 ml vial there. And that is as part of a TIVA or total intravenous anaesthesia anaesthetic. And then thirdly, we use it for sedation. So certainly in ICU, it's used a lot. We tend to just run it in mils an hour as opposed to effect site concentration like we use in theatre. In theatre, we use it for often as sedation. It's probably the most common thing to use as sedation when coupled with a spinal anaesthetic, for example. So if somebody's getting a hip or a knee replacement, we often run TCI propofol. Obviously, you might see other things like midazolam being used instead of propofol. So propofol is well known for giving what we call a smooth induction. So patients just slowly drift off to sleep. And the beauty of it is it doesn't hang around for ages as well. So if you give it as a single bolus, the patients will often wake up within a few minutes if you don't continue to give them things to keep them asleep, such as volatile or more propofol. And it comes in these two different sizes. So 1% is two different concentrations and two different vial sizes, beg your pardon. So 1% being the one on the right, 2% being the one on the left. So 1% meaning 10 milligrams a mil, 2% meaning 20 milligrams a mil. So we're going to talk a wee bit about the pharmacodynamics of all the different induction drugs now. Again, continuing with propofol, pharmacodynamics is basically a fancy way of saying what the drug does to the body. Okay. So I've divided these up into different systems. So respiratory / airway, cardiovascular, central nervous system, and just some other features. So the kind of common respiratory ones, so you get suppression of laryngeal reflexes, you can get respiratory depression, i.e. they drop their minute ventilation, and this can progress to apnea if you give big enough doses, particularly in combination with opiates. It can also upturn the patient's response to hypercarbia, as in if your arterial CO2 goes up, it needs to be a bit of a higher level in order for the patient to breathe at the same rate they would if they were awake. Suppression of the laryngeal reflexes is where propofol's kind of initially gained its popularity because it was coming in at the same time as LMAs were coming into use. So you can imagine if you get somebody off to sleep and they've still got laryngeal reflexes and then you put an LMA down and stimulate their larynx or irritate their larynx, you risk laryngospasm, and propofol negates that. And it's actually what we use to treat laryngospasm, or part of the treatment of laryngospasm. So cardiovascular, you get an overall reduction in blood pressure, okay, and there are 4 main reasons of that. In fact, it essentially affects all the things that keep your blood pressure at a decent level, okay. So the heart rate, the stroke volume, and the systemic vascular resistance are all affected, okay, and all reduced. Your cardiac output is a combination of your heart rate and your stroke volume. So by reducing all these things, you get a reduction in blood pressure. And it's pretty predictable. You know if you give somebody a big, huge dose of propofol that they're likely to drop their blood pressure. So it's why we need to be a wee bit careful when we're injecting it in people we expect to be more cardiovascularly unstable. So people who have had MIs in the past or are on whacking doses of antihypertensives or whatever, or who might be bleeding, for example. Its effects on the central nervous system, are pretty logical when you think about it. So you get a reduction in the cerebral oxygen consumption. So basically that means that the amount of oxygen that your brain is using per minute when you're sedated or even anaesthetised, you can imagine that your brain's having a bit of a rest and doesn't need to use as much oxygen per minute. And because of that, you also get a reduction in intracranial pressure as well. There are a few other things that we see. So if you've been in theatre and seen somebody going off to sleep, it's not uncommon that you'll have seen them complaining of pain on injection with propofol. The beauty of that is it's a temporary thing and it's gone by the time the patient wakes up, but it can certainly be very unpleasant. Some of us try to negate it by putting in some lignocaine. It doesn't always get rid of that pain, unfortunately, but if you warn patients about it and tell them that it will be gone by the time they wake up, that's probably reasonable enough, as long as they know to expect that. The really good thing about propofol is it's got an antiemetic property, or it's got antiemetic properties. So this is the beauty of using it for something like total intravenous anaesthesia. Sevoflurane or a volatile anaesthetic in general can often make you feel pretty sick afterwards. So if people are high risk for post-operative nausea and vomiting, using a propofol infusion is a good option for them. The reason we don't use it as much as we would like is that we need to use that in combination with a BIS monitor, and access to BIS monitors is not fantastic at the moment. When propofol first came out, there was a small number of papers. There was a paper which wasn't a greatly designed paper that suggested it might be associated with allergy and anaphylaxis, particularly in people with either egg or soy allergies. Actually, over time, we've realised that this isn't the case, and allergy to propofol itself is very, very rare. The egg protein is what people are usually allergic to, and actually it's stuff that's found in the egg yolk that is involved in the manufacture of propofol. The next drug we'll talk about is ketamine. So ketamine is a drug that's been around for absolutely ages. It's particularly beloved of our A&E colleagues and can be used for induction, but actually you'll probably more see it being used for analgesia and as sedation. It's a drug that gets used as to supplement analgesia, particularly in big cases, big GI cases. Often you'll see a dose of ketamine getting used. And it can be used in sedation for things like pulling ankles, reducing fractures, changing burns. The dose of analgesia is between 0.2 and 0.5 milligrams per kilo. But sometimes patients end up in ketamine infusions post-operatively. They have to be given in a kind of higher level of care, so like an HDU as a minimum usually. It can also be used for induction of anaesthesia, and it tends to be, some people use it as their go-to drug for a cardiovascularly unstable patient. We'll explain why in a wee second. The dose is obviously bigger, so between 1 to 2 milligrams per kilo. It can also be used in a particularly agitated patient who doesn't have IV access as an intramuscular injection, so up to 10 milligrams per kilo. It's an NMDA receptor antagonist, so that's the same receptors that nitrous oxide works at, which is why you get pain relief as well as anaesthesia with bigger doses. So ketamine's got a lot of advantages compared to other drugs such as propofol. So the beauty of ketamine is patients keep on breathing, which is why it works really well in certain sedative environments. The patients will tend to not go apneic, they'll increase their respiratory rate, and it's also great for asthmatics. So critically unwell asthmatics, we can use ketamine infusions, or can be used as induction because it's a potent bronchodilator. Its cardiovascular effects are its main advantage. whilst with propofol we saw it slowed down the heart rate, it decreased the cardiac output. Ketamine, in theory and on paper anyway, is supposed to do the opposite of that. The theory being that if you keep up somebody's cardiac output and their heart rate, then you don't get the same drop in blood pressure. What we end up seeing in reality is that ketamine induction will still drop your blood pressure, but you don't get quite as pronounced as effect as you would with propofol, for example. The kind of central nervous system effects are the things that really hold back its use. So it increases your cerebral oxygen consumption. So it's not appropriate for people who have had head injuries or have got other reasons for increased intracranial cerebral oxygen consumption. So like status epilepticus, for example. You get a dissociative anaesthesia. So what that I like to think of that is kind of you get this removal in time and space of where your brain is basically. You kind of see that with people who we give ketamine to, is they're not quite in the room in a different way to with other IV sedative drugs. But the main things are you can get pretty distressing hallucinations, and certainly patients can experience delirium with it, and delirium is associated with worse outcomes. So generally we try to avoid drugs that are deliriogenic. So that doesn't mean that ketamine doesn't have its place, but it's important to consider its use in certain patients. So moving on to thiopentone, it's probably a drug that you've heard of. It was the kind of classical RSI drug of choice, particularly in obstetrics, but it's fallen out of favour over the last few years, and it's really not. Probably over the last sort of 10 years, maybe a wee bit longer, I suppose. To the point where it's not a drug that's used particularly commonly anymore. Part of that is to do with something called the NAP5 study, which investigated accidental awareness under general anaesthesia and found that thiopentone, there was an association between people who got thiopentone and people who had accidental awareness, which is probably made it kind of fall out of favour a wee bit. So much so that if you go to the obstetric department, you'll most likely see propofol being used for induction of general anaesthesia there. Thio is a wee bit different to the other drugs in that it comes as a powder which you need to reconstitute with water. The dose range you can see is pretty massive, between 3 and 7 milligrams per kilo, so that's more than double of a difference. So most of us go for about 5 milligrams and inject it, and that's usually fine. What's different with thio compared to the other ones is you often get bronchoconstriction. There are some books that suggest you can get laryngospasm with it as well, and you get respiratory depression in the same way that you see with propofol. Similarly to propofol, you get a drop in your blood pressure, so a reduction in your stroke volume, a reduction in your systemic vascular resistance. The things to say about that is, particularly in sick patients who may be acidotic or may have lower amounts of proteins kicking about in their blood for the drug to bind to, these cardiovascular effects can really be exaggerated in people who are particularly critically unwell. So it's not something you commonly see being used much anyway, but certainly in an intensive care population it'd be very unusual to see it being used at induction. One of the kind of indications that it may still have is in people with status epilepticus. I certainly know a few ICU consultants, or certainly one that I can think of, that would still go with status epilepticus for as an indication to use thiopentone, because it offers profound burst suppression. It really kind of shuts down the brain, if you like, which will reduce their intracranial pressure, reduce the blood flow to the brain, and reduce the oxygen consumption of the brain. So for people who have got, having status epilepticus, or they've got a traumatic head injury or something like that, thiopentone is still a drug to consider. But again, most of us, particularly in neuroanaesthesia, will still use propofol, both for induction and for maintenance of anaesthesia and sedation in the ICU afterwards. A few other things that have kind of limit thiopentone's use and can have some pretty nasty consequences are if you inject it to somewhere that's not a vein. So either an accidental arterial injection or extravasation, which basically means the drug spilling out with the vein and going into the surrounding tissues, whether that be subcutaneous or otherwise. You can get necrosis of these tissues and pretty nasty injuries from them. Arterial injection can lead to essentially ischemia of the limb, and patients have lost arms and fingers and things in the past from accidental arterial injection of thiopentone. So for all these kind of reasons coupled together, most of us don't. It's not a drug that a lot of us use anymore, but you still will see it in the cupboard. And the last one to talk about is etomidate. So I'll go through this a wee bit quicker, but essentially etomidate is a drug that I've probably used literally once or twice in my entire training. It seems somewhat of a pity because it was by far and away the most cardiovascularly stable induction agent out of the four. But I was having a look around the theatres and it wasn't even kept in our emergency theatre cupboards, which sort of tells you how often that it's a drug that actually gets used. The reason for that was there was a study that came out in ICU patients where they got infusions of etomidate, and they were associated with increased mortality. So basically, patients who received etomidate infusions died more than patients who didn't receive etomidate infusions. It has shown to cause a decrease in endogenous steroid synthesis, and you need steroids for your blood vessels to be reactive. So cortisol is involved in noradrenaline, in your body being able to respond to noradrenaline. So it was thought that basically these patients were becoming were becoming sicker, partly because of that reason. Now, obviously, we're given this drug as a bolus induction as opposed to an infusion, so they don't necessarily correlate, but it was enough to put people off using etomidate to the point where it essentially fell out of fashion, really, rightly or wrongly. But again, it's not a drug that we see being used anymore, very much anymore. Again, it's got similar central nervous system effects in that it decreases your intracranial pressure, decreases your cerebral metabolic rate. But as I say, it's not a drug that you commonly see used anymore. Okay, so that was a kind of whirlwind tour of induction agents and talking about a few other sort of basic concepts. So we touched on the difference between a bolus versus an infusion. A lot of this talk focused on propofol, and that's for the main reason that it's the drug that we use the most often. Other drugs are available and certainly have their uses, and probably the one that you'd see used second to propofol would be ketamine, but more so again for analgesic and sedative uses as opposed to induction. None of these drugs are perfect, and they all have their potential for dangerous side effects, particularly if not used properly or used in excess. Mostly, the most common things are respiratory, cardiovascular, and neurological. But you can kind of hopefully combine that with what we talked about between boluses and infusions at the start to have an idea of how anaesthetists would maybe use these drugs to and try and use them in a way which would limit the side effects while still getting the actual effect that you want, i.e. the patient being anaesthetised. Okay, thanks very much for listening to that. Hopefully that was helpful. Bye-bye.